The TAILORx trial was a large phase 3 randomized clinical trial comparing adjuvant endocrine therapy to chemotherapy plus adjuvant endocrine therapy for patients that had intermediate recurrence score. And the rationale behind the trial is that when we evaluated chemotherapy benefit in an old NSABP study, B20, it appeared that benefit from chemotherapy was large in patients that have a high recurrence score and non-existent for patients that had a low recurrence score. But that left us in the middle with an intermediate recurrence score category, which we weren't quite sure if it was benefit for chemotherapy or not. So the TAILORx was designed to take a large number of these patients and randomize them to chemotherapy plus endocrine therapy or endocrine therapy alone to show whether there is or isn't benefit from adjuvant chemotherapy for that population, to define then better who we should treat with adjuvant chemotherapy and who we should not. The TAILORx study was very impactful because it gave us a very definitive result, essentially that there is no benefit for chemotherapy for patients of recurrence score of 11 to 25. So now we can define the cutoff when we start adjuvant chemotherapy with recurrence score of 25 or more. However, there was a little bit of an interaction with age. So patients that are younger than 50 appear to receive some chemotherapy benefit, even if they had a recurrence score of 16 to 25. So the TAILORx helped us define who needs chemotherapy, who doesn't, but it's not necessarily the same population for patients over the age of 50 and in patients under the age of 50. Under the age of 50, the cutoff where we consider chemotherapy is recurrence score of 16 and or 11 at least, but 16 more importantly. But for women over 50, the cutoff is 25 or higher. We recommend chemotherapy. Under 25, we do not. The TAILORx, again, was very instrumental in actually defining cutoffs because before TAILORx, we were very uncertain about what to do with patients with recurrence score 11 to 25. We ended up giving them chemotherapy just to be safe. But with the TAILORx, we have very strong data to suggest that for over 50, recurrence score under 25, there's no benefit from chemotherapy. And for women under 50, recurrence score under 16, there's really no benefit. And for sure, under 11, we knew there was no chemotherapy benefit because those patients were treated with endocrine therapy alone in TAILORx. In terms of prognosis, the recurrence score is very prognostic of outcome, for sure. However, clinical pathologic factors also play a role in addition to the recurrence score. For example, if let's say you have a recurrence score of 10, you have X risk of recurrence or distant recurrence at 10 years. If your tumor is 1 centimeter versus if your tumor is 4 centimeters, the risk of recurrence is a little bit different. So obviously it will be more for a tumor 4 centimeters versus 1 centimeter. So you do not eliminate clinical pathologic factors for the prognostic algorithm, but the recurrence score is more important than those factors and has to be in the algorithm to better define prognosis. So the results of the TAILORx actually give patients certainty in terms of making a decision regarding chemotherapy or not. With the TAILORx, before TAILORx, recurrence score of 11 to 25, we were not sure if chemotherapy should be used or not. We ended up giving it because we didn't have any data. But now that we have the data, we can with certainty tell patients that under 25, if you're over 50, you're not going to benefit from chemotherapy, therefore you should not take it. And even if you're under 50, if your recurrence score under 16 pretty much, there's not much benefit from chemotherapy, and therefore you should not get it. So the cutoffs may be a little different between younger and older patients, but it gives patients certainty in making a decision regarding chemotherapy use.